Please note all lab values for the fluid and electrolyte lecture will be based on Brunner 15th edition, and you might notice that you get different lab values depending on which resource you use. This is very common. This lecture does not cover acid and base balances, and if you click on this link or use this link, it should direct you to the library guide and a free electronic copy of Fluid and Electrolytes Made Incredibly Easy.
We are going to start with fluid compartments. So when we are talking about these fluid compartments, this information is for an adult client weighing about 70 kilograms. So 60% of adult body weight is fluid and electrolytes. It's divided into intracellular and extracellular fluid. You can see in the image, the intracellular fluid is the yellow-orange, and then we have our extracellular fluid, which has two sections, and we're going to talk about that in a second, but that's going to be the green and the pink. Intracellular fluid is fluid in the cells, both tissue and blood cells. It's about 40% of body weight, or about 28 liters. Then we have our extracellular fluid. So extracellular fluid is further divided into interstitial and intravascular, the plasma, and also transcellular fluid. So it's fluid that is outside of the cells. Again, those two subgroups, the big ones that we have, are going to be interstitial fluid, which surrounds the cells. It's about 10 liters, and it's going to be that lymph fluid. And then we have intravascular fluid, which is fluid in the blood vessels. It's about 3.5 liters, and it's a small area, but it's very important because this is where we base our lab samples on. So the intravascular is extremely important, even though it's a very small space, because that's actually where we're getting our lab samples and how we help our clients. It's based a lot on that information. And then we also have transcellular fluid, which is the smallest space of the extracellular fluid, and it's about 1 liter. And that transcellular, it's going to be cerebrospinal fluid, the GI tract, sweat, digestive secretions. Extracellular fluid is going to be important because it transports electrolytes, so a loss or gain in volume can disrupt the equilibrium of the body. We will look at some of the common ways that the body regulates fluids and electrolytes and what commonly may happen when there's a gain or a loss that occurs. And just so you're aware, third spacing, it's loss of extracellular fluid into a space not contributing to equilibrium. That's the definition of third spacing. Factors affecting amount of body water. As we said in the previous slide, for a 70 kilogram client, the average amount of body water is going to be about 60%. So gender is one of these factors that will affect the amount of body water. And women are going to have less body fluid compared to men, and it's due to their percentage of fat. Men are going to be about 60%, whereas women are 50%. The percentage of body fat, as stated previously, fat holds less fluid than muscle. So women and the obese are going to have less body fluid. Then we look at age. So infants are going to be about 75 to 80% body weight, or body water for weight, whereas the adult is 60%. A healthy infant has a greater need for more water than an adult pound for pound. It's clear because they have a higher percentage of body fluid, so they have a greater need for that fluid. So in your textbook, there's some information about this, and I'm going to give you that. For more information about calculating the fluid requirements, you're going to want to go to Pilitary on page 1260. It breaks it down for you. So up to 10 kilograms, they're going to need 100 milliliters per kilogram for 24 hours. And if they're 11 to 20 kilograms, their needs are going to be 1,000 milliliters plus 50 kilograms for each kilogram over 10. So it's a little complicated, but if you actually do the math out, infants are going to have a greater need. The smaller kids, the infants that lower weight, they have a higher percentage of body water, so they have a higher need. And then we also have to look at elderly. So elderly lose muscle with aging, so it decreases their body water percentage decreases to about 45% of fluid body weight. Fluid balance in children and elderly. So in children, body weight is going to be the big thing with this. Infants can become depleted of fluid faster than adults for some of the following reasons. As we talked about a moment ago, they have a greater proportion of water to body weight. Their metabolic rate is greater. It's actually 2 to 3 times greater than adults, so fevers tend to be higher, and changes are more rapid in children with acute illnesses, which increases fluid loss with diaphoresis. Then we have renal function. So kidneys are immature and do not concentrate urine as well as adults. So they're prone to proportionally greater fluid loss in urine. Then we have their respiratory rate, and it's faster, causing increased insensible, which is unmeasurable, fluid loss. So for an infant between 0 and 6 months, their respiratory rate is going to be about 30 to 60. And 1 to 5 years, it's about 20 to 30. So that's significantly higher than what we're looking at for adults. Then we have our body surface area. So area of external surface of the body to body mass increases insensible fluid loss. So this is more important for children with altered airways, such as having a tracheostomy, or those requiring suctioning. They're going to be at a higher risk for fluid loss. Now we're going to look at the elderly. So at around age 65, they're going to be around 45% body weight for that water, and about 45%, and it can cause fluid overload if they go above it, and if they drop below that 45, it can put them at a risk for fluid volume deficit. Then we have renal function. So renal function declines with age, so we have decreased renal reserve. They're not necessarily able to concentrate urine as well. They're not able to filter things out as well. It can cause more problems. Then we have cardiovascular function, so decreased cardiovascular or cardiac reserve, and they're unable to handle even small changes in their fluid volume. We have alterations in fluid and electrolytes that can cause minor changes in younger age groups, may cause profound changes in the elderly because they're unable to handle the changes as easily. When I'm talking about younger age groups, I'm talking about adults still, but not over 65. Okay, fluid in should equal fluid out, and that's what normally happens. We need to make sure that we are keeping track of all areas of intake and output for our clients. So we have fluid intake. Now, fluid intake, it can be PO, it can be alternate methods if the patient is NPO. So always make sure that you're thinking of those IV fluids, tube feeds, whatever else is going in. And even when you're giving medications, clients a lot of times are taking those medications with water. Make sure you're counting that as well. Then we have the fluid content of food. So certain foods we count in our I's and O's. We went over this last semester. As we break down foods, they're going to release water as well, which can be part of it. So in a total 24-hour period, we're thinking 2,000 to 3,000 mLs. And output. So what is considered output? We have insensible losses, those things that can't be measured, such as evaporation and perspiration, respirations, and losing fluid through the lungs. But what else is considered output? So if someone's throwing up, we're measuring that. If they have loose watery stool, we're probably going to want to measure that, or at least keep track, do a stool count. We have urine that we're going to measure. So there's so many different things that we are actually keeping track and measuring. In infants, we actually weigh the diapers themselves to determine how much they're actually excreting. So it's not limited to urine. Urine is the largest, and then feces is going to be the smallest usually, because normally the body will absorb all the fluid out of the stool, so, or at least absorb a good amount of fluid out of the stool. Then lungs are another source that it's not measurable, so if a client is having difficulty breathing, they will be losing more fluid. If they are diaphoretic, they're also going to be losing more. So in hospitalized patients, there is more likelihood that conditions are not normal for them, and so they're going to need to be monitored closely. People don't come to the hospital because they're healthy. They come because something else is going on, and we need to make sure that we are monitoring these I's and O's to help them get better, to help make sure that they're not losing too much fluid or gaining too much fluid as well.
Fluid provides a method for electrolytes to maintain equilibrium in the body. It is constantly changing to maintain that equilibrium. Major cations in the extracellular fluid and intracellular fluid are listed on the top row of each side. Any deviation from the normal values should alert the nurse to monitor the patient closely. When we're looking at these, we've got Na, which is sodium, Ca, calcium, K, potassium, Mg, magnesium, Cl, chloride, SO4, sulfate, HCO3, bicarbonate, and HPO4, which is phosphate. This lecture really focuses on common labs that we're going to look at, and you guys have probably reviewed some of these, but I just wanted to compile a little slide or two to help you guys really focus in on some of the ones that are going to be really important for fluid and electrolytes. So we have our CBC, our CMP, and our BMP. Obviously, doctors can order extra things and add things on as well, but our CBC, it's our complete blood count. It includes white blood cells, hemoglobin, hematocrit, red blood cells, and a lot more going on in there as well. Then we have our CMP. It's our comprehensive metabolic panel. It includes electrolytes, glucose level, kidney and liver function, just to name a couple of the things that can be included in there. And then sometimes instead of a CMP, it may be in order for a BMP, a basic metabolic panel. Again, it's very similar to the CMP, but it doesn't have as much in it. But the CMP and BMP give us a really good understanding of our clients' kidney functions. And that's one of the big things that we're thinking about with fluid and electrolyte balances, because the kidney function will affect that as well. Included in a BMP and a CMP, some of these things might overlap, they might not, but we've got our BUN, which is our blood urea nitrogen. We got our creatinine. And I just did a quick thing about why we're looking at them. So our BUN, it's telling us about the kidney function, how they're filtering out waste if it's building up in the bloodstream for clients. The creatinine, it's going to become elevated with decreased renal function. So if the kidneys aren't functioning as well, they're not clearing these things out, then these levels can become elevated. Then we have our GFR. It can be a test that's added on. It might be included in some of the CMPs, but doctors can always add it on as well. And this is our filtration rate. How well are the kidneys functioning with that blood flow? So it's telling us what's going on with the kidneys a little bit more, and it can show chronic kidney disease. And this is going to come to be extremely important when we're looking at different types of electrolyte and fluid imbalances, because our kidneys really are the powerhouse with that, and it can give us a lot of information as to what's causing the underlying issues with our clients.
On this slide, you're going to notice just the reference values. Again, I just listed this for you so you have a quick point of reference in the slides if you needed it. Okay, we're going to review some terminology. So this should be a review. I recommend checking out Brunner 14th edition on page 253 if this is confusing for you. So we have our milliequivalents, and this is a unit of measure. We have osmosis, which is the movement of water from an area of less concentration to an area of greater concentration. Water moves to dilute more concentrated substances. So you can see the direction of movement in the image. There's more solutes, more of that dissolved stuff on the left side. So fluid, the water, is actually trying to move to dilute that. Then we have diffusion, and this is passive transport of molecules from an area of higher concentration to an area of lower concentration. And the best example for this one is gas. And then we have filtration. So filtration, fluid and solutes move across a membrane from one compartment to another. movement of fluid from an area of high pressure to an area of low pressure. An example is going to be blood. It moves from the arteries, which are higher in pressure, to the capillaries, which are lower in pressure, and this is also known as hydrostatic pressure. Then we have active transport and passive transport. So active transportation requires energy to move substances through a cell from an area of lesser concentration to an area of greater concentration, whereas passive does not require energy. So diffusion and osmosis, those are passive. Now we have some more terminology, and it's hydrostatic pressure, which I mentioned a moment ago. Hydrostatic pressure, it's that pushing out pressure. It pushes fluid for circulation by the force of the heart contracting. The movement is from high pressure to low pressure. Onconic pressure is the osmotic pressure exerted by proteins such as albumin. So onconic pressure, it's pulling pressure. It's the opposite to hydrostatic pressure. It's pressure created from plasma proteins and other solutes in the blood, and it holds fluid in the blood vessels. So it's pulling fluid in to maintain the blood pressure. So albumin is a plasma protein and it pumps up the cells. Our goal is to have a balance between the two. So what happens with edema? Well, there's an imbalance that we're seeing. So the hydrostatic pressure is greater than that of the onconic pressure. It could be possibly from decreased in the albumin level. So the pushing pressure is greater than the pulling pressure, and we can end up with fluid in the interstitial space, otherwise known as edema. Okay, so what happens with a hemorrhage? This will cause a decrease in the hydrostatic pressure due to the decreased volume in the blood vessels. There's not enough fluid in there, so the pressure is going to decrease. So this will decrease the blood pressure if the loss itself is greater than 15 to 30% or 750 to 1,500 milliliters. It can lead to shock. Now, our body will try to regulate this due to compensatory mechanisms that include the sympathetic nervous system stimulation. So we're going to see vasoconstriction, an increase in heart rate, and a decrease in urine output while our body tries to respond to that decrease in circulating volume.
The urinary system is extremely important in the balance of fluid and electrolytes. So the kidneys filter and regulate this, and they have the following functions. They filter metabolic waste, toxins, excess ions, and water from the blood and excrete them as urine. If kidney function is impaired, these substances reach toxic levels and damage body cells. The kidneys also help to regulate blood volume, blood pressure, electrolyte levels, acid-base balance by selectively reabsorbing water and other substances. They also play a role in the renin-angiotensin-aldosterone system. They create urine. The ureters transport that to the bladder that stores it until it can be expelled.
Kidneys' role in fluid and electrolyte balance. So what do the kidneys do? They're going to rid the body of waste products such as creatinine and urea, which is blood urea nitrogen. They're going to help maintain an acid-base balance, which will be covered in nursing 3. So again, please don't panic about acid and base balance yet. You have plenty of time to worry about that in nursing 3. They are also going to help maintain that fluid and electrolyte balance through the secretion and suppression of certain hormones such as ADH, which is antidiuretic hormone, and aldosterone, which we are going to cover in detail.
So what is the difference between urinary retention and low urine output? The reason we have this slide is because a lot of people are mixing these two concepts up. Urinary retention means that the body is making urine. We're able to make urine, the kidneys are functioning, hopefully, and that urine is kind of stuck in the bladder for whatever reason. We're not getting it out of the body from the bladder. Okay, that is urinary retention. It could be an obstruction. It could be the client's not feeling that urgency to go. Something else is going on. Waking up from anesthesia can slow this down. Okay, so that would be urinary retention. We have urine in the bladder. For whatever reason, we're not getting it out of the bladder. Okay, then we have low urine output. What this could mean is that the kidneys aren't getting enough blood flow, maybe. They're not able to make urine. They have decreased ability to function, so we're actually not making as much urine. So the two ideas, like in essence, a client could have a urine void of 0, and it could be urinary retention or low urine output, but it depends on, is that urine stuck in the bladder, or is the client not even making urine in general? Like there's nothing in the bladder because the kidneys aren't actually creating urine. So it's a different concept to think about, low urine output versus urinary retention, and just make sure you can differentiate that for practice.
Now let's take a look at aldosterone. So I'm going to review the renin-angiotensin-aldosterone system. I want you to understand the basics and be able to apply the information, but I don't expect you to have the entire system memorized. And once you hear me go over it, I think you will understand why I do not expect you to have this memorized. It's a little bit complex. The basics that I want you to get are, why is aldosterone secreted? What does aldosterone do? What happens if there's too much, if there's not enough aldosterone? I want you to pick up on that. So how is it secreted? It's a feedback loop. So blood flow to the glomerulus drops, and there's decrease in pressure picked up by the baroreceptors in the left atrium and the carotid and aortic arches. So there's decreased fluid volume in the body, and the kidneys pick it up, and so does the heart, pretty much. The juxtaglomerular cells secrete renin into the bloodstream. So this is that renin aspect of the renin-angiotensin-aldosterone system. Renin travels to the liver, where it converts angiotensinogen into angiotensin. Yeah, try getting those like straight and not mixing them up. That's a little bit hard. And it's angiotensin 1. Angiotensin 1 travels to the lungs, and it is converted into angiotensin 2. Angiotensin 2 then travels to the adrenal gland, stimulating the adrenal gland to produce aldosterone. So if there's a fall in blood pressure from decreased intake of fluid or from fluid loss itself, such as like a hemorrhage, the purpose is to maintain body fluid volume. So it conserves sodium, chloride, and water. So aldosterone gets secreted when the volumes are low, and it conserves sodium. And wherever sodium goes, so will water. So aldosterone promotes the conservation of sodium, chloride, and water, and the secretion of potassium and hydrogen. Because it causes the body to retain sodium, this causes the body to also retain water. Where salt goes, water will go. You need to memorize that due to osmosis. It also stimulates thirst, helping us to increase our fluid volume as well. Now we have another kidney hormone, which is the antidiuretic hormone, ADH. It's a hormone that regulates body fluid and osmolality, which is that concentration, and it's secreted from the hypothalamus that signals the posterior pituitary, which is our thirst center. It can also be stimulated by a drop in blood pressure or volume. It causes thirst. It's stimulated by the hypothalamus, which is our thirst mechanism. So one of the ways this one works is you're outside on a hot day and you're running around. This will stimulate antidiuretic hormone production when you lose fluid due to sweat. Your body will then work to retain fluid in the kidneys and stimulate you to drink from the hypothalamus, thus increasing the volume in your system. So it increases the kidney's ability to retain fluid, and urine is going to become more concentrated. So antidiuretic hormone, it's not specifically looking at salt. Make sure you're able to pick up the differences between our aldosterone and antidiuretic hormone. You need to be able to differentiate between the two of them and what makes them work and how they are different. So we have cases where we can have antidiuretic hormone functioning abnormally. So if we have increased production, it's called the syndrome of inappropriate antidiuretic hormone, and it's going to cause increased fluid to be retained. If we have decreased antidiuretic hormone, it can be due to diabetes insipidus, where they have extreme thirst and enormous urinary loss, and fluid is lost in this case. So this is an image. It's in Brunner on page 257. The outside circle is antidiuretic hormone, where the inside is aldosterone. Different hormones are stimulated to both increase the blood volume and return blood concentrations to normal. They aid the body to restore circulating fluid volume, very helpful in fluid volume deficit. So really, the big key thing here is we have fluid loss. Our blood is going to get more concentrated. We have hemiconcentration. We're going to have compensatory mechanisms that are going to take effect, such as increased thirst in drinking, or that conservation of water due to decreased output. We're going to have increased blood dilution because now that we're getting more fluid in, it will help to dilute the blood and increase our volume, moving back towards normal. So these are our primary regulators of fluid intake, and when the mechanism fails is when we end up with dehydration. So we just looked at the kidneys. Now we're going to look at the heart and blood vessels because those also affect fluid and volume, or fluid and electrolyte balances. In this case, it's actually going to be something that's doing the opposite of that antidiuretic hormone and the aldosterone. So aldosterone and antidiuretic hormone were helping us increase our fluid volume. Now we're going to get something that's helping decrease it. So the heart propels blood to perfuse the kidneys. Baroreceptors sense pressure in that aortic arch and regulate blood pressure and the pulse. The ANP, atrial natriuretic peptide, can pick up on a stretch in the atria, and it releases this hormone to excrete sodium and water. So this hormone acts as the opposite of antidiuretic hormone and aldosterone to decrease blood volume that is too high. So this is going to aid in fluid volume excess. It acts in the atria of the heart where there is so much blood volume that it actually causes those cardiac cells to stretch. ANP levels are measured in the blood plasma and are elevated with acute heart failure or any condition that causes volume expansion. The normal value is 20 to 77 nanograms per milliliter. The level can decrease with chronic heart failure and with some medications such as Elanopril. Make sure you can differentiate between each one of these hormones and identify when they're going to act in the blood system or in the body. So if there's too much volume, if there's not enough volume, when are they going to take effect and what are they going to do? When IV solutions are necessary. So we have our tonicity, which is the concentration of particles as related to plasma within the infusion. It's the ability of solutes to cause an osmotic driving force that promotes water movement from one compartment to another. So see the images on the left? We can see how fluid is moving in or out of them based on the different type of fluid being used. It determines the normal state of cell hydration and cell size. So isotonic, as I covered a little bit before, it's equal. So the isotonic extracellular fluid is going to be equivalent to intracellular fluid. So it helps just increase volume. Then we have our hypertonic solution, which is going to be the one in the bottom left. So hypertonic, it pulls fluid from the cell into the intravascular space. Hypertonic solutions contain more solute, which is dissolved particles. The cells will shrink and the intravascular space will expand. Then we have our hypotonic solutions, which are going to be the top left. and it pushes fluid into the cells from the intravascular space. A smaller number of solutes, so it expands the cells. So think hypotonic, hypo, hippo. It turns the cells into little hippos. It expands them. It's used for cellular dehydration or hypernatremia. Okay, so different types of electrolyte solutions. We've got normal saline, 5% dextrose and water, or lactated ringers are 3 IV solutions that are isotonic. So make sure you're able to identify these by all of their different names. Can you figure out the tonicity of the other IV solutions with this information? We have NaCl 0.45%. I highly recommend you pause the slide, see if you can do it yourself. If you can't, I'm going to go over the answers now. So we have half strength saline. It supplies daily water needs and water for excretion. It also gives sodium and chloride, and it is a hypotonic solution. So this is half normal saline. So that 0.45 is half normal saline, and it's hypotonic. Then we have NaCl 0.9%. This is normal saline. It is an isotonic solution, so it expands extracellular fluid volume. Then we have NaCl 3 to 5%. This is a hypertonic solution. It's hypertonic saline. So 3 to 5%. It's got increased amounts of sodium in there. It corrects severe sodium depletion, and it decreases cellular swelling. It's given at a slow rate on an IV pump. Then we have Ringer's lactate, aka LR, or lactated ringers. So you can see all of those names. It can be Ringer's lactate, LR, or lactated ringers, which is really fun. It's all the same thing. It's an isotonic fluid. It contains sodium, potassium, calcium, and lactate, which is a salt. It's routine electrolyte replacement. So you want to make sure that you're monitoring those kidney functions, though, because we've got potassium and some electrolytes in there. And it only contains 9 calories per bag, so it's not enough for an actual supplement for food. Then we have D5W, which is our 5% dextrose and water, D5W. It's isotonic. There's no electrolytes. It supplies calories, and it's 170 per bag, and it's free water to excrete and quickly metabolize. Fluid volume deficit or hypovolemia. Those two terms can be used interchangeably. Make sure you are comfortable with both. So fluid volume deficit or hypovolemia, the most common type is isotonic fluid loss, where you lose more fluid than you absorb. This can be due to diarrhea, or you absorb less fluid than you excrete from vomiting. And it's going to be in equal amounts with the electrolytes. Isotonic is going to be equal. You can also have hypertonic dehydration if more fluid is lost than electrolytes, and electrolytes are in a higher concentration in the bloodstream. Also, there is hypotonic dehydration, which is increased loss of electrolytes versus fluid. There's a great chart in Pillitary, the 8th edition, on page 1260 that covers the signs and symptoms of each type of dehydration. I highly recommend you are able to differentiate between them and pick out those differences. So we have increased fluid loss for hypovolemia due to GI tract. It can be diarrhea, vomiting, NG tube drainage. That's going to be a big one. It pops up a lot. Make sure you know about nasogastric tube drainage. If we are pulling everything out and not putting enough back in, we're going to have hypovolemia. We can have acute GI conditions preventing PO intake, such as an obstruction or gastritis. Then we have systemic infections with wound drainage. You can have copious loss of fluids due to those two things. Then we have a hemorrhage. This is loss of circulating volume. You're bleeding out. You are going to lose the volume in your system. Diuresis, increased fluid loss through urine. Diabetes insipidus, it's decreased production of that antidiuretic hormone. and it leads to large quantities of dilute urine, usually caused by a tumor putting pressure on the pituitary gland or invading the pituitary gland. Then we have decreased intake. Um, the elderly are going to be at the highest risk, especially those with decreased cognition. Some people restrict their intake due to incontinence as well. People will refuse to drink because they are concerned or worried or embarrassed that they're going to be incontinent later. We also have the inability to obtain fluids independently. So we have elderly clients that are stuck in bed and the water and water pitcher are placed outside of their reach, higher risk for fluid volume deficit. We have anorexia, especially for cancer patients that are on chemo. They're not able to take anything in. Those that are nauseous, unable to take the fluid in or keep it down. And then fasting for diagnostic tests. And also severe respiratory disease. You are breathing so hard that you can't eat or drink because it's too much work. Those are all factors that could lead to fluid volume deficit.
So there are 3 different types of fluid volume deficit. Isotonic fluid volume deficit, we lost both fluid and sodium in equal amounts, and this is the most common. For this one, we would have what's known, or what we would see is a, within defined limits, sodium level. Then we have our hypertonic fluid volume deficit, where we lost more fluid than sodium. It's going to be hypertonic because our sodium is going to be elevated. And then our hypotonic fluid volume deficit, we lost more sodium than fluid, so our sodium level is going to be low. It's going to look dilute.
Signs and symptoms of dehydration. So thirst is an early sign, but it's unreliable in the young and elderly. Then we have weight loss. So make sure that we are doing daily weights for clients if we're concerned about their fluid volumes. 1 liter is going to be equivalent to 1 kilogram. 2% weight loss is mild. Greater than 15% can be fatal. Vital signs. We're going to watch for shock. So shock can occur if the loss is greater than 25% or when the loss is rapid. We can see an increase in the pulse as compensation by the body to help keep that cardiac output normalized. The pulse can become weak and thready as the fluid volume deficit continues, especially if it's not being corrected. Blood pressure is a later sign because there's not enough fluid to maintain that blood pressure. And we can see orthostatic changes. So a person who is sitting or lying in bed goes to the sitting position and then goes to standing. As they're changing position, their blood pressure can drop further, so you need to be very careful with that. Temperature can be elevated with severe dehydration. Next, we have decreased central venous pressure. It's pressure on the major blood vessels, and it can be measured usually in a critical care setting or specialized unit. They're going to be measuring these, not on a lot of the standardized floors. The normal range is going to be between 4 and 12 millimeters of mercury. Then we have flat neck veins, but this is also a normal assessment finding. It becomes more important when we look at fluid volume excess with those neck veins. But flat neck veins, it's a normal assessment, but we're going to see it with fluid volume deficit. Then we have our cool, clammy, pale skin and dry mucous membranes. It's going to be pale due to peripheral vasoconstriction. And make sure that you guys check those mucous membranes, especially in the mouth and the tongue, because we want to make sure that we're not seeing cracks, that we're not seeing issues. If a person is not taking fluid in because it's uncomfortable, because it hurts, because their oral mucosa is damaged in some way, we may need to get them a lidocaine rinse so that then they can actually eat and get enough food and fluids. Then we have our decreased skin turgor. You may see tenting, especially in the elderly. We want to make sure that we are checking on the center of the body. So we're thinking the sternum or the forehead. With infants, the skin is very elastic, so it's not necessarily as reliable. But if you do see tenting on an infant, that is a huge indicator of that fluid volume deficit. We have prolonged capillary refill time due, again, to that peripheral vasoconstriction. Confusion, it can progress from anxiety to confusion to unconsciousness as dehydration goes from mild to severe. And then we have a depressed fontanelle, and that's going to be for infants less than 18 months old where the fontanelle hasn't closed yet, and that's shown in the picture on the left. Signs and symptoms continued. We're going to see increased hematocrit greater than 55%. The normal for males is going to be 42 to 52%, and females it's about 35 to 47. So it'll look increased because there's less fluid to dilute it. Then we have increased BUN, blood urea nitrogen level. The normal is going to be between 10 and 20 milligrams per deciliter. The ratio will be greater than 20 to 1 with creatinine, and creatinine is normally 0.7 to 1.4 milligrams per deciliter. Then we have our serum osmolarity, which will be increased. The normal is going to be between 279 to 290 osmoles per kilogram. We're going to see olguria or anuria, which is no or minimal urine, less than that 30 milliliters per hour in adults and less for children. So children, it's going to be about less than 25 milliliters per hour. And in infants, it goes down further. So the normal for infants is going to be 10 milliliters per hour, and we're going to see less than that. So the normal urine output for adults, or at least the minimum amount, is going to be 30 milliliters per hour. For children, it's 25, and for infants, it's 10. And we're also going to see dry diapers and less than 1 milliliter per kilogram per hour if you want to do the math out for it. Okay, urine is going to be more concentrated, so the specific gravity is going to be elevated. The normal is 1.01 to 1.025. So we're going to see increased urine osmolality, and it's going to be darker in color. And then we're also going to see serum electrolyte changes, which we'll go into in a little bit. Here we have an image of an infant that currently has fluid volume deficit. Take note of the sunken eyes, tearless crying, sunken fontanelle, and reduced level of consciousness. So nursing interventions. What are we going to do to help a client experiencing fluid volume deficit? We're going to monitor intake and output, especially urine output and any IV fluids that are going in, what they're drinking. We're going to do daily weights because 1 liter of fluid is equivalent to how much weight. Make sure that you have that down and memorized. We're going to monitor assessments. So what's changing? Are we seeing improved skin turgor, their level of consciousness, what's going on with our client? We're going to hydrate. We would start with PO, so small amounts of electrolyte solutions, depending on the type of dehydration. We could do Gatorade or Pedialyte, and make sure to ask preferences when possible. And then we can do IV fluid, so we may administer an IV fluid, usually an isotonic fluid. Fluid challenges can be given for clients. It's when a fluid is given at a rate of 100 to 200 milliliters for 15 minutes. So 100 to 200 milliliters over 15 minutes. So that's a lot of fluid over a little tiny bit of time, which is why it's called a fluid challenge. Make sure that they have a well-working IV site. This would depend on the patient's ability to handle the volume and any other medical conditions such as cardiac conditions that they may have. Be mindful of potassium. So you're going to learn more about potassium later, but potassium is excreted in the urine. So if a client is not making urine, We do not want to give potassium because it can build up in the body and cause a lot of problems. So you need to be extremely careful with potassium and watching urine output. I hope you picked up on that one. That is extremely important. I highly recommend you memorize that because if you do not, you're going to miss the test question. Now we're going to look at fluid volume excess or hypervolemia. Make sure you can use those interchangeably. The definition is isotonic expansion of the extracellular fluid, abnormal retention of sodium and water in about the same proportions, and it leads to increase in total body water. Okay, retained fluid and sodium equally. So what fluid compartments will the isotonic fluid sit? It's going to be that extracellular. So contributing factors can include renal conditions in failure, so damage to the kidney structures, resulting in the inability of the kidneys to filter body waste and eliminate the waste products and fluids. Then we have heart failure. So weakened conditions of the heart due to coronary artery disease, valvular disease, heart attack, whatever it might be. The heart is unable to work as effectively. The body will try to compensate, but eventually it is unable to. The sympathetic nervous system will increase the heart rate to try and maintain the cardiac output. It will also constrict blood vessels in the periphery and in the kidneys, and this will cause the renin-angiotensin-aldosterone system to be stimulated, which, if we remember correctly, aldosterone will actually cause us to conserve more fluid, and this will compound the problem, leading to fluid volume excess. Then we have cirrhosis. So normal liver tissue is replaced with fibrous tissue, resulting in the inability of the liver to synthesize proteins. Portal circulation becomes blocked, and the blood backs up into the GI tract and the spleen, causing accumulation of fluid in the peritoneal cavity. This is an example of third spacing. Because the fluid is not in a normal space, it may make it seem like the client is actually in a fluid volume deficit, but they are pooling fluid in the wrong area. So it's an example of fluid volume excess. Then we have excessive isotonic IV fluid. So fluid volume overload may occur when receiving IV fluid, especially in children and in those with some of the health issues that we just listed. So make sure that we're monitoring IV fluid carefully, discontinuing it when it's no longer needed, and watching the client's response to it closely. We have high corticosteroid levels. This can be due to stress or medications such as steroids like prednisone. It elevates the blood pressure and can affect the adrenal glands, including aldosterone production. So make sure you know what aldosterone does so that you can understand why it could lead to fluid volume excess. Then again, we have this primary aldosterone syndrome, which is high aldosterone levels, usually caused by a tumor leading to excessive aldosterone production. It leads to the conservation of sodium, increasing the blood pressure and concentration of body fluids, even though the client has polyuria. Now let's look at a hypotonic fluid excess. So this means there's more fluid than the solute sodium. So it can be due to repeated plain water enemas, large quantities of salt-poor fluids, hypotonic, specifically in children through the use of tap water enemas. It leads to transfer of the fluid from the extracellular to the interstitial and possibly intracellular spaces to restore normal osmosis. It can also be due to overuse of hypotonic IV solutions that increase the intracellular compartment. Excessive plain water ingestion, so literally you're drinking too much fluid, specifically water. Drinking excessive amounts of plain water can also cause that hypotonic fluid excess. And excessive antidiuretic hormone secretions, which we already said is that syndrome of inappropriate antidiuretic hormone. It can result from intracranial pressure. We have increased secretions of antidiuretic hormone causing volume overload and decreased urine output. So the treatment for this one would be fluid restrictions. Now we have fluid volume excess due to hypertonic situations. So this is going to be ingestion of excessive amounts of table or other sodium salts. So large quantities of salts will also cause water conservation in an attempt to restore equilibrium. So it's fluid volume excess. We ate too much salt. Our body is trying to conserve water to help dilute that, so it's hypertonic and fluid volume excess. It can also be due to excessive administration of sodium-containing fluids. So this is why we use a lot of caution when we're working with hypertonic solutions. Hypertonic saline solutions are used to treat symptomatic hyponatremia and increase extracellular fluid. So it pulls fluid into the plasma compartment, and too much can cause fluid volume excess. So our signs and symptoms of fluid volume excess. We're going to see increased weight. So 1 liter is equivalent to how many kilograms? I've said this a few times now, so I really hope that you have it memorized at this point. Then we have various types of edema. The first one, so edema forms from increased hydrostatic pressure, decreased serum osmotic pressure, and increased capillary permeability. So the fluid is moving from that high pressure to low pressure, and it gets kind of trapped there. We have dependent edema. It's caused by increased hydrostatic pressure, which pushes the fluid out, and it becomes stuck. Then we have ascites, and it's a form of third spacing where fluid moves into the peritoneal cavity. And this is the one that we were talking about previously with the issues with the liver. We see ascites a lot when there's issues with the liver. Then we have anascaria, which is extreme generalized edema, like the child pictured on the right. Then we have brawny edema, where there is so much fluid that there is no pitting and the skin is tight. I've seen that one a few times. You can actually see weeping through the skin if it's tight enough and there's so much fluid. Make sure you guys can differentiate between the types of pitting edema. So 1 is minimal, whereas 4 is severe. 4, you push down and it doesn't respond quickly, and the pitting will remain for a while. What role does gravity play? So think about clients that are sitting with their legs down and end up with swollen ankles. What's one of the first things that we'll do? We'll elevate their feet. The hydrostatic pressure is strong, so it's pushing that fluid down, but they're not able to get the fluid to move back up independently. So what do? We put stockings on them. We make sure that their legs are elevated whenever possible. Those things help keep the fluid moving in the correct way. And how do we monitor it? Again, that pitting edema and the degree of the pitting. So we want to check for pitting edema. We also can measure the circumference of extremities or the abdominal girth, depending on where that edema is. So if they're having ascites, we may want to measure their abdominal girth to see how bad the ascites is, if it's changing, if it's improving. So signs and symptoms, continued circulatory overload. We're going to end up, so circulatory overload, there's too much fluid in the system. What are we going to see? Those distended neck veins. So remember we said that the neck veins wouldn't be distended if it was fluid volume deficit. Because there's so much fluid, we're going to see those jugular veins are distended. And to view that, you want the client in semi-Fowler's position with the head supported on a small pillow. And you would note how far up from the sternal angle the vein is distended. You will also notice puffy eyelids and edema. A bulging fontanelle if they're under 18 months, because again it closes after 18 months. You're going to see tachycardia, a full bounding pulse due to hydrostatic pressure. There's so much fluid, it's causing a lot more pressure. Then we have increase in blood pressure as well. Increased central venous pressure. So again, that normal is 4 to 12. Then we're going to have crackles in the bases of the lungs. because the fluid is going to start going in there. We have decreased urine output in clients with impaired renal or cardiac reserve. The normal kidneys and cardiac function will lead to polyuria. So if your kidneys are working properly, then we'll actually produce urine. If they're not able to work properly, then we're going to end up with issues where we're not producing urine, so it's going to cause more issues. We need to make sure that we are watching people very closely with that. We're going to have a weight gain, and 2.2 pounds is equivalent to how many kilograms, which is equivalent to how many liters of fluid. Make sure you can do that. And then we have decreased hematocrit and BUN, which is our blood urea nitrogen, because there is so much fluid that it's diluted. Whereas previously with fluid volume deficit, it actually looked higher because it was more concentrated. In this case, it looks lower because it's diluted. So fluid volume excess can lead to circulatory overload and or pulmonary edema. So we're going to see some of these signs and symptoms: coughing and shortness of breath, increased respirations, dyspnea, crackles. Why are we seeing these things? Why are we specifically seeing coughing, shortness of breath, increased respirations? Well, blood and fluid are going to back up into the lungs when the left ventricle cannot handle the volume overload anymore. The increase in hydrostatic pressure in the heart, in the atria, and the pulmonary circulation, it forces fluid out into the lungs. It has nowhere else to go, so it starts going into the lungs. So if you are seeing a client with some of these signs and symptoms and they have IV fluid running, one of the first things you're going to do is stop that fluid. So then we have extreme fluid excess. We have gurgling in the lungs, pink frothy sputum. It's when fluid in the alveoli mix with air producing pink frothy sputum. Literally, it's coming up through their lungs. We're going to see pallor and cyanosis. Gas is impaired, causing a lack of oxygen in the bloodstream and in the brain, and the lack of O2 will cause pallor and cyanosis, and the client will become restless and anxious. They're pretty much at this point drowning in their own fluids. If you were in that situation, you would be restless and anxious as well. Something is wrong. Our O2 saturation is going to be low. They do not have enough oxygen. It's an emergency situation, so what do? The patient is drowning in their own secretions. We want to sit them up in high fowlers. Often the feet are dependent. At this moment, do we even care about dependent edema, or do we want to get that fluid off the lungs? If their ankles swell, their ankles swell. If they can't breathe, they're not going to live long enough to care about their ankles swelling. So we have a priority here. We want to assess the airway and breathing, determine the severity. So how far up the chest is the abnormality noted? We're going to want vital signs, a chest x-ray, IV access, usually for IV push, diuretics. And we're going to look at some of those in a little bit. So what do we do for fluid volume excess? We want to do I's and O's because we want to know what's going in and what's going out. Guys, this is fluid volume. So obviously I's and O's, it's going to be one of those, we always want to do it. Then we have daily weights. We want them to wear the same clothes, have it at the same time, use the same scale, make sure you know how many liters is equivalent to how many pounds is equivalent to how many kilograms. We're going to check for edema, checking the locations and what we're rating it on for pitting. Is it getting better? Is it getting worse? We're checking abdominal girth. We want to mark the area where we're measuring and measure at the same site every time. So make sure that it's marked. Make sure we're using the same equipment to be able to measure it. If they have a distended abdomen, we want to look at it from the side to see how bad the distension is. We're looking for tight, glistening skin or brawny edema. Are we seeing that really tight? Is there fluid literally leaking out of the skin because it's so tight at that point? A fluid wave is a test for ascites. You press down, you lift your hand up, and you can see like a wave go through the abdomen. That means there's a good amount of fluid in there. We're going to watch our vital signs, including our heart rate and our blood pressure. And we're going to make sure we do a really good pulmonary assessment and make sure that the lung sounds are clear, because if we're hearing crackles, if we're hearing any of those issues, that could mean that the fluid is going back into the lungs. So more interventions. We can restrict intake as ordered. So it may be indicated depending on the type of fluid volume excess that they need. Fluid restrictions could be related to the amount of urine output. It could be a sodium restriction as well. So use common sense with fluid restrictions. If the client only has 2,000 milliliters for a 24-hour period, make sure you leave fluid for the overnight shift so that the client can take their medications with fluid and actually get them down. Let's see, we have diuretics. They block fluid reabsorption in the nephron of the kidney. The more potent the diuretic, the further up the nephron the fluid is blocked. So water and electrolytes are eliminated. So we have to make sure that we are watching for imbalances with this. We would want to give diuretics early in the day and monitor urine output throughout. If it's given late in the day, it will keep clients up all night. We want to make sure that we monitor daily weight. A gain or a loss can have a large impact, especially when we're talking about our elderly clients. So change position slowly, because a decrease in fluid volume can lower the blood pressure. We want to monitor our potassium levels, make sure that they know when to take supplements and when to avoid them. Also watch salt substitutes, because they use potassium to replace sodium. So if a client is having high potassium levels and they're taking a lot of salt substitutes, that could be why. So the first medication that we have is going to be our furosemide. It's a loop diuretic. It's very, very potent. It can be given IV or PO, and it works very quickly. And it does not conserve potassium, so potassium is lost in the urine. Then we have our hydrochlorothiazide, which is our most common. It's given PO a lot of times, and its potassium, again, is lost in the urine. And then we have our spironolactone. Please forgive me if I pronounce that incorrectly yet again. It's potassium sparing. So if they're on a potassium supplement, it can actually build up in their system. This one is usually PO as well. Make sure you guys know these medications, know your potassium sparing, know those that are not potassium sparing, and what to look for with that. Sodium, 135 to 145. It is the most abundant electrolyte in the extracellular fluid. The primary role is to regulate the extracellular fluid, role in regulating water balance in the body, along with antidiuretic hormone and the renin-angiotensin-aldosterone system. It aids in the transmission of nerve impulses and muscle contraction. It's found in most body secretions, including saliva, intestinal secretions, bile, and pancreatic secretions. It's commonly eliminated through the skin in sweat and in the kidneys and urine. The average diet is 5 to 6 grams of sodium or more. Let's look at hyponatremia, which is less than 135 milliequivalents per liter. And the risk for hyponatremia can exist with a fluid volume deficit or a fluid volume excess. The first we're going to look at is a fluid volume deficit. So it's risk for sodium in excess of water, so we're losing both. Related conditions can be due to that GI tract, through vomiting and diarrhea, tap water enemas, especially in children, and nasogastric tube drainage. So if we're pulling out a lot with that nasogastric tube, one of the options that a doctor might order is actually to flush the nasogastric tube with normal saline to help replace that sodium that we're losing. But that's usually for extreme situations, and you would want to have a written order as to how frequently to do it, how much we're using. It would have to be very, very detailed. Then we also have the use of diuretics. So diuretics, you're losing sodium and other electrolytes, can lead to that fluid volume deficit and also the loss of potassium. We have draining wounds. They're losing a lot of fluids. It can be wounds or fistulas, and we're losing sodium and fluid through that. And then we have aldosterone deficiency, And remember, aldosterone would help us conserve water and sodium together. So if we don't have enough aldosterone, then it can actually cause us to lose sodium and fluids. Then we have a risk for gain of water in excess of sodium. So we're getting too much fluid. Okay, so related conditions can be that SIADH. This is the antidiuretic hormone where we're getting um, excess is released, and it could be caused by a head trauma. So remember, that's the syndrome of inappropriate antidiuretic hormone. Too much antidiuretic hormone is released, and it could be due to the head trauma, causes us to hold on to way too much fluid. Then we have our renal failure, and we're unable to conserve sodium. It could be due to medications associated with water retention, such as oxytocin and certain tranquilizers, and also SSRIs, which are selective serotonin reuptake inhibitors, such as Prozac, which its generic name is fluoxetine. You can also have excessive drinking of water and electrolyte poor IV solutions, so half normal saline. They're getting too much fluid without enough sodium. Okay, hyponatremia. So the faster the sodium loss occurs, the more pronounced the signs and symptoms will be. So clinical observations vary greatly, but can include, remember, it's not limited just to this. Make sure you read up in the book and understand all of the different clinical observations. So we can see mental status changes, including confusion and lethargy, muscle twitching, abdominal symptoms, including nausea, vomiting, and anorexia, seizures, and coma as it progresses. And the main cause of this is cellular edema and cerebral edema. So neurological changes take place as extracellular fluid, sodium, decreases. The cells become more concentrated and pull water into the cells due to osmosis. So we're going to have serious clinical consequences occurring when sodium falls to 125. When it falls to 115, you will see signs of increasing intracranial pressure. And remember, it's because when the sodium levels outside of the cell fall, the fluid is going to move into the cells. It's that hypo-hippo. So the cells are swelling up, they're getting big. As it falls below 110, it is a serious medical emergency. So make sure to keep track of this. The reason we're seeing all of those different mental status changes is because of that edema in the brain.
You're going to notice a few slides like this. What I want you to do is look at the electrolyte it's affiliated with, high or low, and then start at the tippy top and work your way all the way to the bottom throughout the body and connect where we're seeing some of these electrolyte imbalances. This is great for my visual learners, people who need to see and make those connections. This is for you.
Our interventions. We're going to assess clinical manifestations. So what are we seeing in the client? What is characteristic of hyponatremia? We're going to monitor intake and output. It's going to be a given on most of these that we are monitoring intake and output. We're going to check the serum sodium and serum osmolality. So the normal osmolality is going to be 279 to 290 osmoles. Osmolality will increase with dehydration and decrease with overhydration. So we need to know which is taking place to understand how to treat the hyponatremia. Because as we looked at before, it can happen if there's too much fluid or not enough fluid. So we need to identify what's going on to be able to treat it properly. So we'll do sodium replacements, PO or IV. It's often lactated ringers or normal saline. But if a hypertonic solution is used, it must be on a pump. This would usually be in an ICU setting, and we must increase the sodium level very slowly because if we do it too quickly, it can cause neurologic damage. PO replacements would include foods and fluids high in sodium. And depending on the cause, a client may need fluid restriction if it's dilutional hyponatremia. Now we have hypernatremia, so it's going to be greater than that 145. Intake of sodium in excess of water, so common conditions can be from a hypertonic tube feeding without water administration. It can cause osmotic diuresis. Normally, you would want to give a water bolus every 4 to 6 hours if somebody is getting a hypertonic tube feeding. It can be through the excessive use of table salt. It can be through parenteral administration of saline solutions like a hypertonic solution. It can be due to hyperaldosteronism. This increases sodium, increased sodium is retained, increased water, and decreased potassium. So we end up just holding on because aldosterone helps us conserve our sodium. We have loss of water in excess of sodium. So our common conditions are going to be profuse watery diarrhea, especially in infants, decreased antidiuretic hormone production. So this can be from diabetes insipidus due to a tumor or a head surgery or trauma. And for this case, if it's decreased antidiuretic hormone, we would actually replace the antidiuretic hormone with desmopressin or DDAVP, which is the brand name for synthetic antidiuretic hormone. And then also through, we can have this through water deprivation. So the person is literally just not getting enough water, or excessive insensible water loss, hyperventilation, or fever and heat stroke. Clinical observations include SALT, skin flushing, agitation, restlessness or irritability, low-grade fever, increased body temperature, and thirst. The main cause is cellular dehydration, concentrated extracellular fluid. So thirst is going to be intense for the stimulation of the hypothalamus and increased osmolality. The very ill and older adults may have impaired thirst mechanisms and may not show this as a sign. Then we have restlessness, disorientation, and change in mental status as well. Think about what's happening in our cells in our brain if they're shrinking. If there's too much or too little fluid, it's not going to function properly. Then we have our dry, sticky mucous membranes. The tongue will be red, dry, and swollen, and we're going to see that cellular dehydration. The cells will shrink due to cellular dehydration, and we're going to see increased plasma osmolality above 300 osmoles. So what do we want to do about this? What are our interventions? We're going to monitor for those clinical manifestations that we just listed, which remember, that's not everything. Make sure you reference the book and get all of those details and have them down very well. Make sure we're watching our I's and O's. With everything, we will be watching our I's and O's. We're going to monitor our serum sodium levels, including our serum osmolality. We're going to lower the sodium levels slowly with IV fluids to get it back to normal at a rate that is no greater than 0.5 to 1 MEQ per hour. This allows time for cellular diffusion to occur. We would give a hypotonic or isotonic solution, and we want to do it slowly because if we do it too quickly, it can cause cerebral edema, and due to this, we may actually give diuretics to lower the sodium as well. We would want to encourage PO fluids and foods that are low in sodium. So you're not going to go and order Chinese food. You're not going to give them pretzels that are covered in salt. You're not going to give them potato chips, and you're not going to give them the chicken broth that's high in sodium. You're going to have to check the foods and make sure that things are accurate. Then sometimes the clients will have that slightly elevated temperature with hypernatremia, but it should return to normal when the level is normalized. So you would just watch our vital signs to make sure that that's okay as well. Let's take a look at potassium. So we're thinking 3.5 to 5 milliequivalents per liter. It's a major intracellular electrolyte, and smaller minor changes can be very significant. Only about 2% is in the extracellular fluid. It aids in skeletal and heart muscle activity, so changes in potassium can cause heart muscle irritability and changes in rhythm. 80% of potassium is excreted daily by the kidneys. They regulate excretion, but they cannot conserve it well. So we need functioning kidneys to maintain a balance with this. Aldosterone also increases potassium loss by retaining sodium, and those two work in an inverted relationship. We're going to start with hypokalemia, so it's going to be less than that 3.5. And we can have excessive losses from the body. Common conditions for this include through the GI tract losses, through vomiting, diarrhea, fistulas of the small and large intestines, and gastric suctioning through an NG tube. So nasogastric tubes, we lose a lot of potassium when we're sucking it out through the NG tubes. Then we have diuretics. We've talked a little bit about these. We have potassium-losing diuretics, such as loop and thiazide, so make sure you can identify which diuretics those are. Then it can also be through poor intake, so people that are alcoholics or those suffering with anorexia aren't taking enough in, and since we lose 80% in our urine with low intake to start, there's a higher risk of hypokalemia. Then we have hyperaldosteronism. So sodium is retained and potassium is lost in the urine. The renin-angiotensin aldosterone system is causing this. And then we have shifts into cells with certain metabolic conditions. Now, I understand I'm going to talk about a little bit metabolic alkalosis and acidosis with this. I'm not testing you specifically on those conditions. It's more just identifying it as an issue with potassium. So in metabolic alkalosis of the kidneys, we have decreased amounts of hydrogen ions. So hydrogen comes out of the cells and potassium goes into the cells to help maintain that electroneutrality. And then if we have hyperinsulin secretions, potassium is needed for insulin to enter into skeletal muscles. The two are best friends and they travel together. So insulin goes, hey, I've got to get into the cell. And potassium goes, that's cool, I'll go with you. So too much insulin can actually decrease circulating potassium levels. So hypokalemia, think suction. It can be life-threatening, and especially when potassium is below 3. So remember, suction, high risk for potassium loss. We have S is skeletal muscle weakness. We have U waves, which are heart irregularities, the EKG changes that can be seen with hypokalemia. EKG changes you'll learn more about in nursing 3. So potassium loss alters the resting potential of body cells from the heart to the skeletal muscle to the GI tract, so it actually causes a lot of issues. Then we have constipation, decreased bowel motility. We can see a paralytic ileus. The ileus can then lead to nausea, vomiting, and abdominal distension. So if we're already seeing constipation and the constipation actually causes an ileus, which is a blockage, it can actually make the overall problem of hypokalemia worse because we start throwing up and losing even more potassium. It kind of compounds on itself. Then we have toxicity of digitalis, and it's going to be toxic at lower levels in the system. So we always have to watch for toxicity when we're giving digoxin. But in this case, it can actually, the hypokalemia causes our cells to be more susceptible to toxicity. Then we have irregular or weak pulses and ventricular asystole or fibrillation. So we're seeing irregular heartbeats. And orthostatic hypotension because of that decrease in blood pressure. And numbness, otherwise known as paresthesia. So suction is very important when it comes to hypokalemia. So interventions, we do not replace potassium if the client is not urinating. So interventions, no P, no K. If there is no or low urine production below that 30 mLs per hour, You do not administer potassium because it can actually build up quickly in the blood. The best treatment is to increase dietary intake. Know your foods that are high in potassium. Most fruits, vegetables, legumes, whole grains, and milk, meat, and sodium substitutes, as I mentioned earlier. Supplement orally. We can give it with food to prevent gastric irritation. Supplements can cause GI bleeding and abdominal distension and pain and nausea. If you give a potassium pill on an empty stomach, you can make your client throw up. It's not a fun trick. Please do not do that. Whenever possible, give it to them with crackers, with something in their system to help them keep it down. They are large white tablets usually, but they can also be mixable powders or in a liquid form as well. Then we have our IV infusions. Usually we give it slowly, 10 to 20 milliequivalents per hour. It can cause irritation at the IV site. You want to make sure that you have a good IV site. And if there's a decrease in urine output, you want to stop the infusion and call the provider. Okay, hyperkalemia. This is going to be our most dangerous one. It can be due to decreased renal excretion of potassium. So normally this isn't an issue with normally functioning kidneys, but with aging and decreased renal reserve, there's a greater risk of potassium building up in the system. It can also be caused by extensive tissue trauma, so crushing injuries or burns. As the tissue is damaged, potassium is pushed out of the cells. Can be due to metabolic acidosis as hydrogen ions shift into the cells. They push potassium out. We can also have pseudohyperkalemia. This is a false high potassium level without any signs or symptoms. For a very high potassium level, you would actually want to get it rechecked. It can be due to hemolysis of the blood sample where the cells are damaged and that potassium leaks out. A blood sample that is obtained above an IV site flowing with potassium. So literally we're pulling that potassium that we're putting in back out, and that's what we're testing. Or due to, and then we can also have it from hypoaldosteronism and Addison's disease. This is where we have decreased adrenal hormone being excreted, so it leads to potassium loss and sodium loss and potassium retention. So in hypoaldosteronism, we have sodium loss and potassium is retained. So our potassium levels will build up. Certain medications can actually cause this as well. Obviously, potassium chloride, it contains potassium in the name. If we're giving a potassium, it can cause hyperkalemia. Heparin, ACE inhibitors, NSAIDs, beta blockers, and potassium-sparing diuretics. Make sure you can identify your potassium-sparing diuretics. Clinical observations may include, but are not limited to, cardiac effects. Most of the time, cardiac effects are going to be seen if the potassium level is greater than 7. If it's less than 7, it's usually not significant, but they're almost always present if it's greater than 8. We can see disturbances in cardiac conduction, so we're going to see EKG changes that can lead to cardiac arrest. We can see bradycardia and weak and irregular pulses. So remember, potassium helps with muscle function, and our heart is a muscle, so it's going to cause irregularities with that. Then we're going to see skeletal muscle weakness to flaccid muscle paralysis and absence of reflexes. Then we have GI hyperactivity, including intestinal colic and anxiety and irritability. What are our interventions? Some of them are kind of simple. You should really be able to think about these and intervene just logically. So restriction of dietary potassium. Their potassium is high. We're going to stop them from receiving more. So we're going to avoid salt substitutes. because again, we talked about this with sodium. They use potassium to replace the sodium. We're going to discontinue drugs that promote potassium retention. So make sure you can list out a few that promote potassium retention, including ACE inhibitors. We want to stop any drugs that interfere with potassium excretion, including heparin and NSAIDs. We would want to hold potassium-sparing diuretics and potassium supplements. Make sure that you're checking even if a multivitamin has potassium in it, because it's a simple intervention just to stop that. Hold it for a couple of days, see how they respond, and get an order before you just hold it. Let's see, we would want to remove potassium from the body. We can do that through dialysis or an exchange resin, otherwise known as K-Electrolyte, which causes the potassium to exit. So K-Electrolyte, it causes potassium to exit. It causes potassium to bind in the intestine for other cations, and it's eliminated in the stool. It's usually given with sorbitol, a sugar, to promote bowel elimination. We can also give diuretics, but it's specific ones, including our loop diuretics like furosemide. We have a temporary fix. We can administer insulin and glucose. So sometimes people will be given like dextrose IV fluids and given insulin even though they're not diabetics, because insulin and potassium are besties, and insulin goes, hey, potassium, let's go into the cell. And the two of them go into the cell, reducing the circulating potassium level. Does this work forever? No, but it does help. But we need to make sure that we're also giving glucose at the time, because we don't want their circulating glucose levels to drop. Then sodium bicarb can be given in severe metabolic acidosis. As we said, metabolic acidosis can lead to hyperkalemia. Then we also have another option. Now this one can help stabilize cardiac activity temporarily, but it doesn't affect the potassium level. So in an emergency situation, a client may be given calcium gluconate. Make sure you know your different types of calcium as well. There's a couple different ones, and I'm going to review those, but be able to identify the different ones. So calcium gluconate can be given to stabilize cardiac activity temporarily, but it does not affect the potassium level. So if we're seeing some of those cardiac signs and symptoms, we'll give it while we're giving other medications to help lower the actual potassium level. Then we have our beta-2 agonist, such as albuterol. It decreases potassium, but it can cause tachycardia and chest discomfort, so it's not always used for these reasons.
Okay, calcium, 8.8 to 10.4. It's a major component of bones and teeth. About 1% exchanges with blood calcium. It has a role in nerve impulses and muscle contraction, and a role in blood clotting. Hormones regulate the absorption from the GI tract, and calcium is excreted in feces. Calcium absorption is affected by vitamin D, and it's required for it to be absorbed properly. Also, it's affected by phosphorus, which prevents the absorption in the intestines. So calcium and phosphorus will have an inverted relationship. Calcium levels can be affected by the albumin because it is bound to serum proteins, so you may see a corrected calcium level for clients. Hypocalcemia. It can be caused by inadequate intake, poor absorption from the GI tract, or not enough vitamin D. We can have malabsorption syndromes, or even pancreatitis, where calcium ions and fatty acids combine, forming a soap, leading to a decreased calcium level. We can have hyperphosphatemia due to renal failure or renal disease. This causes increased phosphorus, and that decreases our calcium due to that inverse relationship. Hypoparathyroidism. In a normally functioning parathyroid, the parathyroid hormone is released, and that increases calcium absorption in the GI tract. But when we have hypoparathyroidism, it's usually due to surgery or loss or damage of the parathyroid, This leads to decreased calcium, and we would actually need to have calcium gluconate on hand after surgery in case of a sudden drop. Osteoporosis, so older populations can have normal level calciums in their blood sample, but actually have a low total body calcium level because the bones aren't holding on to the calcium the way they need to. And then older adults and those with disabilities that spend increased amounts of time in bed or on bed rest can have increased bone reabsorption of circulating calcium, causing a lower calcium level in the blood.
Hypocalcemia clinical manifestations may include, but are not limited to, spontaneous discharge of motor and sensory fibers in peripheral nerves. We can see tetany, which is most common manifestation of decreased calcium and magnesium. A lot of the calcium and magnesium ones are going to be very, very close together, so pay attention to that. It can help you identify which is which because you need to be able to pick that up. It's a continuous, tetany is a continuous muscle activity that can interfere with breathing and may cause death through dyspnea and laryngospasms. We can see increased neural excitability, so we can see tongue twitching. Again, that can lead to laryngospasms, leading to death. If we can't breathe, we're not going to live. So this is an emergency situation if we start seeing these. We also have Trousseau's sign, which I'm going to go over on a slide coming up. And Chauvet-Steck's sign, again, I'm going to go over it on a slide coming up. I've got nice images for that. Seizures because of brain irritability. So we would actually need to have seizure precautions enacted for our clients. And mental status changes, including hallucinations, confusion, irritability, and anxiety. Okay, this is Trousseau's sign. It is a cardopedal spasms induced with inflating a blood pressure cuff approximately 20 millimeters of mercury over the systolic pressure and leaving it in place for a few minutes, about 2 to 5. So we see adduction of the thumb and a flexed wrist. Please do not try this at home. I am not sure who figured out that this is one of the ways to test for hypocalcemia, but they did, and it doesn't seem very comfortable to me. And normally we don't want to cut off the blood supply or keep a blood pressure cuff on for that long. Now we're going to look at Chauvet-Steck's sign, which is twitching of the muscles innervated by the facial nerve. So what we end up actually seeing is contraction of the facial muscles in response to a light tap over the facial nerve in front of the ear. And we see a grimacing response just on the one side. So whichever side you activate the facial nerve on, that's the side that you're going to see the response. Okay, so we have a client with hypocalcemia. What are we going to do about it? What are our interventions? We're not just going to leave them like that. So we have the administration of calcium salts. This is where it becomes very important to identify your different types of calcium that we can give IV. The first one is calcium gluconate, and this is the most common one that would be given. We also, and these are our IV ones, we have calcium chloride, but this one is more irritating and can cause sloughing of tissue if it infiltrates at the IV site. It also should not be diluted with normal saline because it will increase renal calcium loss. So make sure you check orders and check medications closely between calcium gluconate and calcium chloride. Calcium gluconate is going to be our better medication. It's more ideal and it causes less of an issue, but it has a lower concentration of calcium when compared to calcium chloride. But calcium chloride can cause a lot of issues if it infiltrates, so it's a higher risk medication. Then we have some of our PO options, which include calcium citrate. It's easily digested, and it's usually in a liquid form. Then we have calcium carbonate, which is an antacid. We have calcium acetate and aluminum hydroxide, and these can help to reduce phosphorus levels with certain kidney issues And as we know, if our phosphorus is high, it will cause our calcium to be low. So by decreasing our phosphorus levels, we can increase our calcium levels. Then we have vitamin D therapy. So vitamin D aids in the absorption from the GI tract. So we need to make sure that we have vitamin D so that we actually absorb that calcium. Otherwise, it's just going to run right through our system. Then we also have our increased dietary intake of calcium, and we want about 1,000 to 1,500 milligrams per day. We want to decrease the client's caffeine and alcohol intake in their diet. Large amounts of caffeine and alcohol will actually decrease our calcium absorption from the GI tract. Then we have dietary sources, which include, but are not limited to, our leafy veg, green leafy veg, canned salmon, sardines, oysters. What's our most common source? What do we see all the time? You got milk? It's going to be dairy. Make sure you know your sources.
Hypercalcemia. There are two major causes that we're going to talk about today. The first one is a shift from the bone to the plasma. And in this case, it's a lot of times caused by a malignant tumor. In the bones, it causes bone destruction, releasing that stored calcium into the blood. We can also have increased GI and renal absorption of calcium. This can be due to hyperparathyroidism, which is again often a malignancy. This has the increased hormones causing increased calcium by drawing calcium from the bones and increasing absorption in the intestines and kidneys. Okay, we can have false high levels from excessively tight tourniquets, prolonged blood draws, or dehydration, or also low phosphorus.
So hypercalcemia, clinical manifestations can include, but again, are not limited to, reduced neuromuscular activity. We're going to have suppressed activity from the myoneural junction, decreased tone in smooth and striated muscle, leading to muscle weakness, incoordination, anorexia, nausea, vomiting, and constipation. We can see confusion, lethargy, and coma, and we're going to have a hypercalcemia crisis with levels around 17. So we're saying hypercalcemia takes place if it's above 10.2, and it's a crisis if it's around 17. And this can lead to cardiac arrest. Normally it won't get this high. We'll catch it before it does, ideally, but it can lead to cardiac arrest. Okay, so what are our interventions for hypercalcemia? Well, we're not going to ignore it. We're going to do something about it. We're going to monitor for those clinical manifestations, especially cardiac monitoring for clients if it's high. We want to make sure that we're not going to end up with a cardiac arrest. We want to treat the underlying cause. So if it's cancer, we're going to treat the cancer with surgery or medications, depending on what's going on with the client. We want to administer fluids to dilute and often give furosemide at the same time. Now, I've actually had to do this in practice. So my client had a slightly elevated calcium level. We gave her IV fluids, normal saline, and then I had to give her IV push Lasix. She was high risk also of going into fluid volume excess or overload, so I had to be careful with watching her respiratory status as well. She had a history of CHF. So again, you administer fluids to dilute it, and then often give furosemide. So we dilute the calcium and promote kidney excretion with a normal saline, and the added diuretic effect promotes calcium excretion. Then we can also give calcitonin. It's used in clients with heart and renal disease who can't tolerate large sodium loads. It increased calcium deposits into the bones and prevents it from being reabsorbed into the bloodstream. And it also increases urine excretion of calcium.
Now let's talk about magnesium. So magnesium is important for proper neuromuscular and cardiac functioning. It can lead to muscle overexcitability if it's low, or muscle weakness, incoordination, or even paralysis if it's too high. This is the second most abundant cation in the intracellular fluid, and it's important for muscle contraction, carbohydrate metabolism, protein synthesis, ATP use for energy as well.
Hypomagnesemia. So this is going to be less than 1.8. And low magnesium is actually associated a lot of times with low potassium and low calcium, but it's overlooked a lot of times because those two are going to cause more problems. So really we focus in on them. But common causes of this can be due to poor dietary intake, especially our chronic alcoholics. Those people have poor intestinal absorption and increased loss in urine of their magnesium. Then we have prolonged TPN or IV fluid or even enteral feedings without magnesium replacement. So if we're feeding these people, if we're giving them IV fluid and TPN, which is total parenteral nutrition, and it lacks magnesium, then they're not getting it in their system. So obviously it's going to start going lower. We can have it through poor absorption. So malabsorption syndromes, anytime the intestines aren't absorbing everything that we need. We have poor absorption from Crohn's disease, ulcerative colitis, or bowel surgeries that can decrease surface area in the gut. We can have excessive loss from the GI tract. So magnesium is absorbed in the lower intestine. So it can be caused by like prolonged diarrhea or a fistula drainage, even laxative abuse, or NG tube drainage. So we talked about NG tube drainage being a problem for our potassium. It's also going to be a problem for magnesium. So start looking for those links that are common for our clients. In pancreatitis, just like with our calcium, magnesium and fatty acids are going to form soaps, taking magnesium out of circulation. Now we can have excessive loss from the urinary system as well because we actually get rid of a lot of our magnesium in the urinary system, similar to potassium. So diuretics use, that can boost urinary excretion from loop diuretics or thiazide diuretics, which we've talked about already. We have overproduction of aldosterone. So hyperaldosteronism can cause us to flush out and lose more fluid, losing our magnesium. Hyperparathyroidism. Again, you're seeing a lot of similarities to calcium and potassium, so really pay attention to that. And diabetic ketoacidosis can lead to increased loss through the urinary system. If we're producing a lot of urine, we're going to lose it. Then we have certain medications such as cyclosporins and gentamicin. There's a whole long list of medications that can actually cause you to decrease your magnesium level. And then we have losses with low albumin because, again, it's bound to proteins. So hypomagnesemia, signs and symptoms are going to be similar to potassium and calcium. So make sure you're keeping track of that. And notice starved on these sides. So that's going to be some of your signs and symptoms. Let's see, we have hyperirritability of the central nervous system. So we're going to have altered level of consciousness, apathy, agitation, depression, hallucinations, confusion. We're going to have nerve and muscles hyperirritability. So we're going to see tremors, twitching. We can check for Chauvet-Steck's and Trousseau's sign. We're going to have hyperactive deep tendon reflexes. We can have respiratory muscle weakness and that laryngeal stridor. So we can actually end up having issues with our airway again. For the heart, we can have cardiac arrhythmias and cardiac arrest, including EKG can show Trousseau's day points, which I have on the next slide to show you. And we want constant cardiac monitoring for this. You can see anorexia. So without enough magnesium, we may end up having GI problems, including difficulty swallowing, anorexia, and vomiting. And then we have cardiac glycoside retention increases digoxin toxicity potential. So if your client already has hypomagnesemia and they're on digoxin, we want to watch those levels very, very closely. And so make note of starved. We've got seizures, tetany and dysphagia, anorexia with arrhythmias, rapid heart rate, vomiting, emotional liability, deep tendon reflexes are going to be increased. So this next slide is showing you an abnormal EKG because we talked about EKG changes, and it is Torsades de points. It's a specific type of cardiac rhythm. I didn't specifically go over EKGs. I just want you to understand that there can be EKG changes with regards to abnormal electrolyte levels. Okay, so at this point, we identified a client with hypomagnesemia, and we need to do something about it. So what are our interventions? We're going to assess the mental state and reorient as needed because they can be very anxious. So you actually really want to reassure and reorient as needed. We want to check their neuromuscular status, monitor vital signs, and look for hemodynamic instability. And as I said, make sure to reassure the client to decrease their anxiety level. We want to prepare for seizure precautions and monitor for dysphagia. We're watching that airway and we are looking at that for safety. We need to establish IV access for replacement. We want to replace it as ordered, and we start, depending on the orders, mildly, depending on the level of magnesium in the person's system. So we can do dietary replacement. Sources include green vegetables, nuts, legumes, bananas, and oranges. We can do oral supplements, which could, so a PO medication is magnesium oxide. And then we also have IV or deep IM for more severe depletion. Personally, I have only seen IV utilized because we have IV access. For magnesium replacement. Personally, I haven't seen IM. Doesn't mean that it hasn't been given though. If we are giving IV, make sure you check the order. It comes in different concentrations. You must use a pump. If it's given too quickly, it can actually cause a heart block or a systole. And it's not to exceed 150 milligrams per minute. We want to monitor for signs and symptoms of hypermagnesemia and monitor for urine output. If it's under 100 mLs in 4 hours, you would want to notify the doctor.
Hypermagnesemia. This is a rare imbalance due to renal excretion, but excess may occur with certain conditions. So if a client is healthy and has normal functioning kidneys, a lot of times this is not going to be an issue because they'll be able to excrete that excess. So for this one, we've got renal failure due to poor elimination through the kidneys. This can be due to age or with reduced renal function. Untreated diabetic ketoacidosis. Magnesium is actually being pulled out of cells in this case. Hypoaldosteronism in Addison's disease, adrenal cortical insufficiency. We can have low aldosterone levels. And remember what aldosterone does to potassium. Well, with magnesium and some of these other ones, it's going to be very similar. So we can have excessive intake with too many supplements, excessive use of magnesium-based antacids like milk of magnesia or Maalox, too much replacement with magnesium sulfate from TPN or total parenteral nutrition replacement, or hemodialysis because it's actually used in the process of dialysis. And magnesium is given for seizure control and for pregnancy-induced hypertension. So again, if we're administering too much, that's where we can see this problem. And then we can have false elevation when a tourniquet is too tight or if blood is allowed to hemolyze.
Okay, so what are some of our signs and symptoms? Well, if you have a drowsy client, you're going to suspect hypermagnesemia. Excessive levels depress the central nervous system, and with levels greater than 10, the respiratory center is depressed. So think renal because normally we can excrete it. We have reflexes are going to be decreased. We're going to see EKG changes and hypotension with AV heart block, atrioventricular. We're going to see nervous system depression, specifically the central nervous system depression. Appearance is flushed, and lethargy, drowsiness, and progressing to coma. So what are our interventions for hypermagnesemia? Remember, we want to make sure that they're on an EKG. We need to monitor that heart and see how they're functioning there. We're going to monitor vital signs with attention to respiratory function. If we notice depressed respiratory function, we want to call the MD because the client may actually need to be placed on a ventilator. We're going to monitor our heart rate because the pulse irregularities and watch the blood pressure for hypotension. With the skin, we're going to notice, we're going to watch the skin because it could be flushed and diaphoretic. We have muscular function, so depressed deep tendon reflexes. Do you maybe not want to get them up for a walk right now? Fluids up as ordered, and we want to get the magnesium level down by diluting it. We're going to give diuretics to get it out of the system. So think that's a similar way that we treat calcium, right? Very similar to calcium. So with the diuretics, we're going to have the excretion of excess. And what other levels would we want to watch? If we are giving diuretics, what other electrolyte are we going to have to watch closely? There's a couple of them if we're doing this. So make sure you can kind of tie these pieces in together for your clients. If we're giving furosemide as the diuretic, what other electrolytes are going to be affected? Okay, so orders for calcium gluconate. It is a magnesium antagonist, so it's reversing the cardiovascular effects and the neuromuscular effects of magnesium, so similar to potassium. And if this isn't effective, they may need to have hemodialysis with a magnesium-free dialysis solution to help get it out of their system as well.
Our last electrolyte is phosphorus. It's essential in the proper function of red blood cells, muscles, and the nervous system, and it aids in the release of hemoglobin from oxygen, and it's found mostly in bones and teeth. Okay, depletion occurs with malnutrition, and replacement can be from high phosphorus foods, Nutrifos, or IV preparations. Most commonly, excess relates to renal failure.